Hi students, this is Dr. Wace and welcome to your lecture on the upper limb overview. It's important to remember when we're talking about the upper limb that not only are we talking about the upper arm, lower arm, hand and fingers, but we're also talking about the shoulder area, because remember, just like we had in the lower limb, we had the pelvis as a girdle for the lower limb to attach to. So we have the shoulder as the girdle for the upper limb to attach to. So we'll be talking about the bones of the shoulder, including the clavicle, the scapula, as well as the muscles that are associated with the movement of the arm. So we'll be going into muscles of the chest and a couple of the muscles of the back as well, because their insertion points are onto the arm and therefore they will be involved in movement of the arm. So groups that we'll be talking about: the neck, the shoulder, the arm, forearm, and then the hand and the phalanges or digits. And remember, when we're talking about the phalanges, these are going to be our manual phalanges as opposed to our pedal phalanges, which we saw with the feet. All right, a couple other regions we'll be talking about, specifically the axilla and what is in the axilla and why that's important, the cubital fossa, what's in there and why it's important, carpal tunnel, what's in there and why it's important, as well as a concept that I'll introduce now, but they will also be talking about it in your physical exam lab and clinical correlations, is the carrying angle of the arm. So if you stand in anatomical position with your arm straight down, naturally there is going to be an angle at which the arm deviates outward, and that is called our carrying angle. And normally the carrying angle should be within a range of about 5 to 15 degrees from this vertical line. All right, and then to the right here, just to point out the girdle that's going to be holding your upper limb in place. That includes the clavicle, the scapula, as well as rib 1, and that's going to form the basis, the potential space for the axilla. And again, we're going to be talking about that as we move along. All right, so we'll start with the bones. Like usual, we have the clavicle, also known as our collarbone. Clavicle actually means key, and so it was thought when they first discovered this that it looked like a key, like a skeleton key, if you will. It has two ends, a medial end, and notice the medial end is a little more rounded as opposed to the lateral end. The medial end attaches to your sternum. All right, so we call that the sternal end as well. And the lateral end attaches to the acromion process of the scapula, so we can also call that the acromial end, and it is more flat. All right, so notice that is flat, whereas this is more round. So just by looking at a bone, you should be able to tell which is lateral and which is medial just by a flat surface versus a rounded surface. Next, we'll continue on with that girdle part of the upper limb and talk about the scapula. And the scapula, of course, is this shovel-shaped bone on the back of the thoracic cavity, outside of the ribs, of course. And there is a medial border and a lateral border. All right, the medial border is, of course, going to face towards the vertebral column, and the lateral border is going to face away from the vertebral column toward the arm. A lot of students in the past, I've noticed, like to put the medial part facing outward and then the lateral part facing inward, because naturally it kind of looks like a wing if you do that. But if you do that, of course, then your arm would be in the middle of your back, so obviously that's not going to be correct. So that's the orientation of it. The rest of the items that I have in gray here are items that you should be able to know and identify in a lab setting and on a test. So I'm not going to go over all of them, but I do want to point out some other things to help you with that process. All right, we have a couple angles. We have the superior angle, and the inferior angle. Notice that the superior angle is more of a rounded angle, whereas the inferior angle is more of an acute angle. All right, so the pointy end points down and the rounded end points up. So another way that you can tell orientation. And then at the most distal part, or the most lateral part, we have this glenoid cavity, and that is the socket part of the ball and socket joint for the shoulder joint. So that's where the glenoid cavity would be. And then this surface right here, we are looking at the anterior surface. So this would actually be facing the rib cage. If you see this spine of scapula, that would be the posterior part facing away from the body, facing away from the rib cage. So another way to tell orientation. And then looking at it from a straight on into the glenoid cavity, here's our acromion, where the acromion part of the clavicle would articulate with. And then here we see the coracoid process that is at the anterior part. So the acromion is more posterior, coracoid process is more anterior. All right, so moving on to the actual arm itself. Here is the first bone we'll run into, and this is the humerus. Humerus, not to be confused with humerus, funny, although we will talk later on about one particular nerve that when you hit it gives you that strange feeling, and we often call it, we hit our funny bone, and we actually hit the nerve. So that's somewhat related to the humerus being funny. All right, so we'll get into that later. So where the head is, right here, is what articulates with the glenoid cavity, and so obviously that is going to be the most proximal part, or the most superior part of this bone. And since it's going to be articulating with the glenoid cavity of the scapula, this is going to be the medial part, and then on the other side you have the greater tubercle, which is going to be the lateral part. All right, so now we know medial or lateral. How do we tell the difference between an anterior view and a posterior view? Well, here's the head, medial. Here is the greater tubercle, lateral. If we see the lesser tubercle and the intertubercular groove, or intertubercular sulcus, then we know we are in the anterior part of the bone. All right, just looking at the proximal end. All right, if we don't see the lesser tubercle and the intertubercular groove, and we see instead the attachment for the lateral head of triceps, then we know we're in a posterior portion. All right, then if we look at the distal end, we're only seeing the posterior view here. What we have here is called the olecranon fossa. All right, the olecranon fossa. And the olecranon fossa is always going to be in the posterior. All right, and on the next slide we'll talk a little bit more on what's in the anterior, so you should be able to tell anterior from posterior. But again, everything that's in gray here is are terms that you should be aware of, so make sure you're looking at these bones, getting to what the bones are, and what their different parts are and where they're located, and which is left, which is right, and properly put on the skeleton. All right, just a quick trick though, two more things in this slide. Anterior border is always more pointed than the posterior border. All right, so we've seen this a lot with the lower limb bones, where one side was pointed and the other side was flat, and that's going to be similar for the upper limb bones, where the anterior border is more pointed and the posterior border is, or posterior surface is more flat. The other thing I want to mention about the humerus is that it actually has two necks. So if this is a head, this would be the logical place for where the neck is, and we call that the anatomical, pretend it says anatomical, neck. But the humerus also has a second neck, which is located right here. So this would be the surgical neck of the humerus. And the importance of the surgical neck of the humerus is it is a common place for fractures to occur. And all things aside, it looks like more what a neck of a bone would look like, as opposed to this stunted neck that you have as the anatomical neck. All right, moving on to the distal end. For me, it's easier to tell the anterior from the posterior of the humerus by looking at the distal end of the bone, because there's a lot of anatomy there that, again, in gray, that you need to be responsible for. But on the distal end, you have on either lateral side a large bump and a small bump. The large bump is called our medial epicondyle. The small bump is our lateral epicondyle. And you can feel these bumps on either side of your elbow, the medial one being much larger and the lateral one being much smaller. All right, and in between them, what we have is something called a trochlea. Trochlea actually means pulley, so if you look at this, here would be one wheel, here would be the other wheel, and in the middle would be where the rope would go for a pulley. So notice that the trochlea is on the medial side, and then little head or capitulum is on the lateral side. All right, and these are attachment sites for the bones that are beneath them, the radius and the ulna. The radius being attached to the capitulum and the ulna being attached to the trochlea. All right, as the ulna is attached to the trochlea, it's attached in a very specific way. So this right here is the ulna, and it's got this process called the olecranon process. And when we bend or extend our elbow, that olecranon process fits right here, here's a posterior view, into our olecranon fossa. When we flex our elbow, on the other side we have something called the coronoid process, and that fits right here into the coronoid fossa. All right, so if we're looking at the distal end, the trochlea, capitulum, and coronoid fossa are oriented anteriorly, and the olecranon fossa is oriented posteriorly. So I recommend two things, and we'll talk a little bit more about this in the next couple slides. On your own, flex your elbow, take your other hand, find your olecranon process, which is the point of your elbow, and then extend your elbow. And you can actually feel that olecranon process at some point fitting into that olecranon fossa. It's kind of a neat thing. And I can show you how to do this in lab, but it's one way to actually feel the function as opposed to seeing it. And then I also recommend putting these bones together and seeing how they orient with each other. All right, the next bone is going to be our radius. All right, you can tell the radius because it has this rounded head, and whenever we think of a radius, we think of a circle, right? So this circle of the radius is the head, just beneath it is the neck. Okay, and the bump right below the neck is called the radial tuberosity. And notice that this is an anterior view of the radius, so the radial tuberosity will always be pointing anteriorly when you are in anatomical position. All right, if we look at the cross-section of the bone, notice that in anatomical position, the rounded edge is pointing laterally and the pointed edge is pointing medially. All right, it's important to note that when we are talking about this orientation, we are standing in anatomical position, because that orientation is going to change as soon as we move our arm, okay, in multiple different directions. So the anterior border, the point will face medially, and the rounded edge will face laterally, all right, away from our body. Moving down the anterior, we come to a point on the lateral side, and that is called our styloid process of the radius, or radial styloid process. And since our radius is the outside bone, so the more lateral bone of our arm, if you go down and feel the bump right before your hand on the wrist, that's your styloid process of the radius. All right, so a little bump. Opposite that, you're going to have the ulnar notch, where the ulna will actually fit into the radius. All right, so this, if we look at the, it's not in this view. If we look at the top, the superior view of the head of the radius, it'll obviously be circular, but there will be a little indentation in there, kind of like what we saw with the meniscus of the knee. Not exactly like that. It is cartilage, but it doesn't have the same cup shape. But it is kind of indented like a hollow little crater, and that is designed to fit the capitulum within it. So the capitulum fits right in this little crater and forms a nice articulation and allows that radius to swivel back and forth so that we can rotate our arm. All right, so the next bone, which is going to be our medial bone of the arm standing in anatomical position, this is actually one of my favorite bones because it's just kind of neat looking and different from everything else you see. And it kind of looks like a wrench. All right, so this is the ulna, of course. Anteriorly, you're going to see this, the groove of the wrench, all right, so that which would go around the nut or the bolt, which is called the trochlear notch, all right, and that trochlear notch should always be facing anterior, all right. The coronoid process, which is on the anterior border, also obviously should be facing anterior, and the tip of the olecranon process should be facing anterior as well, although technically the olecranon process is on the back, all right, but the tip of it is facing anteriorly. All right, if we go all the way down to the distal end, we see this bump on the ulna, and that is called the styloid process of the ulna. So if we follow from the medial epicondyle down the medial part of our arm till we reach the bump on our wrist, that's going to be the styloid process of the ulna. All right, and all of this is going to be oriented, again, anteriorly, but notice that the styloid process is kind of medial and slightly posterior. All right, and unlike the radius, the pointed part of this bone is always in anatomical position is going to be facing laterally, and the rounded part is going to be medial. Again, lecturing about this and looking at pictures, static pictures, to me is not very helpful. You'll really start to understand this once you get in the lab, pick up some of these bones, look at the skeleton, see how they're fit together, compare them to what you see and feel in your own body, and then it'll really start coming together. All right, so the hand and the fingers. There's a lot in this particular slide to unpack. So let's begin by looking at this top picture where we see a dorsal view of the hand and a palmar view of the hand. All right, and we'll come back to that in a second, so I just want to give you orientation to that. So this is going to be down here, a palmar view of our right hand. All right, and the digits are pretty much the same as how you would count with the foot. So this is digit 1, that would be your thumb, digit 2, digit 3, digit 4, and digit 5. All right, here you have your carpal bones, and remember we said with the feet you walk on the tar with your tarsals, you drive a car, as in steer, you steer a car with your carpals. All right, so the carpal bones. So here they are listed over here, and they're in gray, so they are definitely something you need to know and pay attention to. And then from that extend out our metacarpals, and the anatomy of that still the same. We have our base, the shaft, and the head. So the base is more proximal, the head is more distal. All right, and then we come to our first set of joints. And this is going to be true also for your foot, although we didn't cover it. The joint between your metacarpals and your phalanges is known as the metacarpal phalangeal joint, or MCP. All right, so between our metacarpals and our phalanges are the MCP joint. And those, if you look at your hand and you look at the palmar surface, so the palm, let's do this in red, right here is the same right here. So the metacarpals are within your palm. And then if you look at the first joint here in your hand, that is where the MCP joint is going to be. So if you look at your fingers, the first big crease in your hand, that is going to be the MCP joint. All right, and then of course you have your proximal phalange. Let me do that in blue. Your proximal phalange, your middle phalange, and your distal phalange of digit 2, digit 3, digit 4, and so on. All right, then we come to our second joint. All right, and all of these are going to be referred to as our PIPs, or proximal interphalangeal joint. So between the phalanges, proximal interphalangeal joint. And then the third joint out would be our DIP, our distal interphalangeal joint. All right, and the reason why I'm making a big deal out of this and going to taking a lot of time to point it out is that this is going to be something that is going to come up in physical exam lab, and they are going to be very, very strict on making sure that you know these joints and test these joints in your physical exam checkoff. So make sure that you actually, if anything, remember these joints and the names of these bones and which digit is which. All right, so this is the palmar view. If you look on the other side to the dorsal view, of course the dorsal, if you stand in an anatomical position, would be facing back, so your back hand, if you will, would be over here. All right, one more thing to mention when we're looking at the carpal bones, they kind of form an arch in your hand. So we call it the carpal arch. If you remember in your foot, there was this, with the tarsal bone, your transverse arch. So this would be very similar to your transverse arch, this carpal arch. So if you pay attention to your hand, if you kind of rest it on the table without, using any muscles, you notice that there is somewhat of a cup to it, all right, and that's a result of that carpal arch. All right, with the veins, the deep veins generally course with arteries of the same name, and they will drain the same area supplied by the artery that's accompanying them. All right, when we get past the axilla here, though, deep veins, except for this axillary vein right here, the deep veins are generally going to be paired. All right, so here we see the axillary vein going with the axillary artery, but once we get past the axillary region, we'll have an artery, and then we'll have these paired veins on either side of the artery. All right, and this arrangement is called, and we've seen this before, vena comitatus. Vena comitatus. All right, so all other deep veins in the upper limb will have this arrangement. And if you look down here, you can kind of see that with the deep veins on either side of this particular artery right here. So keep in mind that arrangement. All right, superficial veins, on the other hand, will be located within the subcutaneous tissue. So, in other words, that superficial layer of fascia that contains fat adipose tissue in it as well. All right, major superficial veins you should be familiar with. the cephalic vein, basilic vein. So notice cephalic is more lateral, basilic is more medial. The median cubital vein, and we will talk about that a little bit later on in the variations in that particular vein. And then notice that these course, actually they'll course upwards, but down in a lower arm following the same pathway. All right, just another view of this cephalic vein and basilic vein. So again, cephalic lateral to your, if you will, biceps brachii, and the basilic vein would be medial to your biceps brachii. And then of course here is your median cubital vein, and you notice that that is kind of a bridge between your cephalic vein and your basilic vein. And for a more complete picture of the flow of venous blood from the fingers through the hand all the way up to the axilla, I recommend looking at page 285 of your bare bones workbook to get a better picture of that. All right, what's not shown in this picture are the veins that are coming from the digits. But again, looking at that picture that we had talked about on the previous slide, you know, the veins would drain the digits in this direction, and they would all drain into this dorsal venous network known as the dorsal venous arch. All right, so this dorsal venous arch would collect the blood coming from the digits, and remember, this is the dorsal side of the hand, hence the dorsal venous arch. And then they would head up on the lateral side are cephalic vein, and on the medial side are basilic vein, and head all the way up the arm, all the way up the forearm, all the way up the arm, and then into their appropriate drainage locations, which we'll talk about in a later lecture. All right, lymphatic pathways are generally going to drain along the same route as your veins, with lymph nodes located in strategic locations where there happens to be either spots for excuse me, the portals of entry for microorganisms, or places that are wet and moist and tend to grow microorganisms, such as your axillary region. So you notice that there are all of these axillary lymph nodes within them, this axillary region, and they are divided into our posterior axillary, lateral axillary or brachial lymph nodes, anterior axillary, mid-axillary, and these are alternative names for them, humeral nodes, subscapular nodes, and then superior axillary nodes, apical and infraclavicular. All right, so you will also have some supraclavicular nodes as well, and I think I have those on a different slide. These are important because these are ones you're going to be feeling for in physical exam, and what you'd really want to have your patient do is lift the arm up so that you can feel within the all those regions of the axillary area for those particular lymph nodes to detect if there is any enlargement of those nodes. All right, so again, this is another one of those clinical correlations, and you'll probably be practicing this in clinical correlations, and I know you'll be doing it in your physical exam lab. The last type on this are your epitrochlear nodes. So those would be on the medial surface of your humerus here, and I just put this picture of this guy right here. You see these nodes that are sticking out on the medial portion of this guy's arm. Those are epitrochlear nodes, and under normal conditions these should not be visible, but under pathological conditions, some sort of infection or other disease process that may be going, cancerous disease process that may be going on, you'll see these lymph nodes enlarged. And so right now I just want to give you a feel for where the epitrochlear nodes are located.